Hi guys. Whether you were in Professor Giesler's class or my own, you probably noticed that we focus quite a bit on the congenital heart defects. And that is partially, or that is very much by design. Um, that is a very pediatric unique topic that you're not really familiar with. And there's so much information, and it's worth it to put a little bit of time into class, trying to get you to understand some of the concepts behind it, because once you master the concepts, it becomes much easier to digest a lot of the other stuff. The other things in the cardiac chapter that are not directly related to these congenital heart defects, we are expecting you to study on your own. It's easier for you to study those things on your own because they're concepts that you're used to, such as how we see here, congestive heart failure. So that is not to say it's not important, and it's definitely going to be on your test, right? Your test isn't just going to be congenital heart defects, just because that's where we spent the majority of our time. So I know that some of you are pretty anxious about some of the other topics, so I'm going to do a little supplemental video where I kind of go through the other concepts here. First of all, congestive heart failure. When you look at this list, none of this should be particularly new to you guys, right? Definitely all of these things generally happen in adults as well as children. There might be just a little bit, some kind of minor differences with maybe something like grunting, right? Since children's alveoli, especially like really young infants, since the alveoli are so small, they're more prone to collapse. They might not even be fully developed in a premature infant. So then you'll have things like that pop up a little bit more for infants than for adults. But when you look at this list of signs here, you should notice that they're fairly similar to what you've seen in adults. So in situations like this, I pretty much say I usually say, hey, focus on the things that are unique to children. And that is definitely true of this time. So your book goes through early signs versus late signs in infants and older children. Definitely, so the older children will look more like what you would expect in adults. So what you kind of want to focus on is the infants area, because sometimes some of these can be a little bit counterintuitive. One of the most counterintuitive things is the weight loss or lack of weight gain for a child with congestive heart failure. When you think about a growth chart of around infancy, you remember that it kind of is, you're supposed to keep on growing all throughout infancy, right? It does kind of slow down, but if you imagine a growth chart in your head, it should kind of look like that. When you imagine a growth chart for an adult over time, it should just be a flat line, right? Adults are not supposed to grow. So because of that, weight gain in an adult is obviously like, hey, unless you change something in your diet, obviously, you shouldn't suddenly be gaining weight. So weight gain is a sign of congestive heart failure in an adult because there's fluid retention. For an infant in congestive heart failure, they're using all this energy trying to beat their heart, so they will start having a different trajectory for their growth, which is lower, right? So then you're going to actually have weight loss or lack of weight gain. They're not going to be meeting their goals as you would hope. So that is a sign of congestive heart failure. Make sure you understand that. Tiring easily, irritability. A lot of this stuff will be very simple for you guys, right? None of this stuff should surprise you. And in a lot of ways, these early signs are signs of them trying to compensate. They're compensating by pulling energy away from growth and instead dedicating it to beating their heart. And that's the same reason why they're tiring easily, same reason why they're being diaphoretic. The frequent respiratory infection is a little unique in that you're starting to see some of the pulmonary signs. Once you get to the late signs, that's when you see a lot of the pulmonary signs, the coughs and crackles. So basically, the infant has pulled every trick in its playbook to try to keep the blood flowing, and they have failed to keep the blood flowing. Because of this failure, it is now building up in the lungs, and that building up in the lungs is causing the nasopharyngeal retractions, causing the pallor cyanosis, and causing more marked tachypnea and tachycardia. So hopefully that progression makes sense when you go from early to late signs. Instead of trying to memorize these two lists, think like, hey, like when I was looking at this list, they're tiring easily, they're irritable, and it's because they were shunting energy away. But there's no signs that that effort has failed. Maybe that effort has succeeded in making up for the fact that they have this congenital heart defect. But once you get to crackles, grunting, retractions, that is a sign that the compensatory mechanisms have failed, and now the child is having late signs of congestive heart failure. So hopefully that makes sense. None of this stuff should be particularly new for you guys. Maybe the serial abdominal measurements, but obviously we do that in adults too, right? When it comes to the medications as well, or yeah, of course, the frequent developmental assessments, they can often get developmentally delayed, but that shouldn't be surprising either. Let's get past these. All right. So when it comes to JIJ, there are different parameters for children because their heart rates are different. For an infant, it's around 90 beats per minute. For children, it's 70 beats per minute. If it's below 90 in an infant or 70 in a child, then you withhold. You do not give the digoxin. Before you give the digoxin, assess for 1 full minute. This is very, very important. In other contexts where it's like time is of the essence and you have to give stuff super fast, sure, maybe you can measure for 6 seconds, maybe you can measure for 10 seconds and just multiply accordingly to get the beats per minute. But for digoxin, it is very important to assess the pulse for 1 full minute. All right, so the rest of the other medications, I don't really go into that much in any kind of detail because they're the same with adults and children, right? You should know how these generally work, but I'm not going to ask you very, very detailed questions about the pharmacology, especially anything from this list. Like, should you give it with food? No, right? I'm not going to tell you those kinds of things. That's a pharmacological thing. I'm focusing on pediatrics. When it comes to cardiomyopathy, there's a lot of different signs, and the signs are, so basically I don't want you to know anything except for just the definition of cardiomyopathy, especially dilated cardiomyopathy, the most common form. Tell me what it is, what it looks like. But other than that, that's all you need to know. With heart transplant, there's nothing really special other than the fact that, of course, a very limited number of donors, true in adults and children, but even more so in children. Pulmonary artery hypertension. So when it comes to different topics for the end chapter, this is one of the most important ones. And that's because one of the reasons why is because you'll see that the most common of the heart defects are heart defects which increase pulmonary blood flow. And so that can cause pulmonary artery hypertension. So in this process, this is blood backing up in the lungs, which then leads to the pulmonary vasoconstriction. That process seems to confuse a lot of people. So make sure you understand that there's more blood going to your lungs, so your lungs respond by vasoconstricting. Generally, blood will go from the left side of the heart to the right side of the heart, right? Especially in like an atrial septal defect. But that's because the pressures are higher on the left side compared to the right side. In a situation where the pulmonary vascular resistance goes up so high that it's actually higher on the right side than the left, then this direction will reverse. This is seen, for example, in tetralogy flow. The pulmonic stenosis causes a very high pressure environment in the right ventricle, so you see the blood actually move toward the left ventricle, opposite of what you would generally expect. So you get the like right to left shunt, and so then here are the signs of pulmonary artery hypertension. And obviously, like we talked about, cardiac cath is used to detect pressures. So if you want to detect the pressures in the pulmonary system, then get a cardiac cath. So now we're at our 3 different acquired heart defects, the like infectious stuff, and it's very easy to get these confused. but I will try to go through them, and then we'll go through kind of how to use just like keywords to get most of the answers right for most of the questions involving these things. So first of all, infective endocarditis. So you'll see here that there's a few different things as factors. The main thing is usually a recent cardiac surgery. It might be pulmonary stenosis. Pulmonary stenosis just happens to have very high rate of infective endocarditis, but usually it's some kind of like, oh, I recently had my CVC position. There's some kind of, I recently had surgery. So whatever that did, it caused some kind of damage. So this injury allows fibrin and platelets to grow, right? Usually bacteria, even if it's floating around your bloodstream, doesn't like to cling on to the heart or anywhere along the blood vessels. Blood's moving so fast, and so it can't really cling on to something, especially in the heart where blood's moving so fast. But if you give it a bed of fibrin and platelets, then the bacteria like to live on that surface. It's a little easier for them. Blood's not going to be flowing as fast, and it allows them to get a little bit more traction onto those walls. So it allows bacterial growth. When it comes to the manifestations, fever, new murmur, those are some things that can happen across some of the other, like with rheumatic fever as well. So it's not super specific, but definitely like you can get congestive heart failure. So really what you're looking for is this association with something that promotes bacterial growth in the heart, some kind of abnormal valve or recent heart surgery, recent repositioning of a central venous catheter. And on top of that, some kind of heart symptoms like a new murmur, signs of congestive heart failure, fever, anything like that. If those two concepts kind of come together, you're looking at infective endocarditis. So definitely when you think about infective endocarditis, this is not one of those very simple diseases, right? This is very hard to treat. So 2 to 8 weeks of antibiotic therapy. And we may have to replace the valve, right? If a hardware is what's infected, then obviously we'll probably need to change it out, right? Poor kid, but what we have to do. All right, rheumatic fever. So rheumatic fever is triggered by a reaction to group A beta hemolytic streptococcus. It's very much a pediatric problem because of the age group. And we don't really know why it happens, but it does. It's just one of those things that your body does. There's a lot of autoimmune responses that are like that. It's hard to figure out what exactly short-circuited in your immune system to cause this weird reaction, but here we are. So you get a streptococcal infection, then a few weeks later, maybe 1 to 3 weeks later, you start having these symptoms, and definitely the joint pain, things like that, and just like non-pruritic rash and all that. But a lot of these things are relatively non-specific. Maybe the joint pain is a little bit specific. But what you're really looking for is this untreated strep infection. The symptoms are going to kind of help you paint the picture, but likely if they're giving you a history, they will say something like, hey, I recently had a sore throat. Or maybe you're asking a question, say, hey, which is the appropriate question to ask a patient? And you'll say, hey, have you had a throat infection recently? Keep in mind that in general, it is going to be a sore throat. That's the vast majority of situations I see, both in real life and in questions. But it can be from any streptococcal infection, strep skin infection, for example. So just keep that in mind. Whatever the reason for the strep infection, it is going to be detected by this anti-streptolysin O titer, right? Did I have that somewhere? So I guess I didn't write it, but so this ASO titer is very important. If you guys remember your clinical packets, they often have titers. Titer levels indicate whether you have been exposed to a certain antigen. In the cases of your vaccinations, usually like a vaccine antigen, but in this case, it's the actual streptococcal antigen. And so this is nice because it'll catch strep from anywhere, and even if the test can't be detected from like a throat swab, we'll still get it here. It's just it's a lot more accurate. We will still want to do the throat swab because we want to know if the strep infection is still there, right? If rheumatic fever is being triggered by a strep infection, the last thing we want to do is to not treat the actual strep infection that's triggering it. They may still be living with that same that bacteria is still living there. So I'm definitely going to treat with antibiotics to take out that strep infection wherever it's at. And then you're going to get aspirin. Over and over again, you've probably heard, don't give aspirin to children, don't give aspirin to children, don't give aspirin to children. There are 3 occasions where we give aspirin to children mentioned in this chapter. 1, post-op for an atrial septal defect. Post-op for an atrial septal defect. And that has to do with the fact that there's the chance for stroke with the atrial septal defect repair. So there's also a risk of stroke for unrepaired atrial septal defects, but atrial septal defect repair as well can cause the atrial arrhythmias, and however you get the atrial arrhythmias can cause strokes. So then you're going to give aspirin for that. Rheumatic fever you're also going to give aspirin for this carditis, for this inflammation that happens. Most children recover fully, but they kind of have a little long road in terms of antibiotics and all that. This is one of the reasons why we want to treat strep infections. So some of the questions I've seen in this is like, hey, a child comes in with like a sore throat, and they're wondering why you need to do the swab. What is a good answer? And one of the answers might be, hey, if untreated bacterial throat infections may lead to heart problems of some kind, or may lead to rheumatic fever, something along those lines. Kawasaki disease. So when it comes to Kawasaki disease, there's a lot of different ways to try to understand it. Most people just look at the list of symptoms and then they'll just try to memorize this big block of text. I will try to explain it to you in a way that hopefully kind of ties into the concepts a little better. So it's acute systemic vasculitis. And it has to do with like certain size of blood vessels. I don't need you to know that kind of detail, right? But basically, your whole body, there are blood vessels all across your entire body becoming inflamed. So think about that. There's pathophysiology for a second. So, okay, all parts of my body, blood vessels are being inflamed, right? So when you kind of compare it to something like rheumatic fever or infective endocarditis, right? And you're trying to like, oh, snap. I remember that one of the acquired heart diseases had a high fever. Which one had the high fever? I forget. You can kind of think, which one caused the most inflammation all around the body? That's Kawasaki disease, right? So the high fever is a lot of times the main presenting like really salient factor. And in any situation where a child has a fever for a long time, we will test for Kawasaki disease. Actually, most cases where a child has a fever for a solid week, it's not because they have Kawasaki, it's because they're unlucky enough to get several viral infections back to back, right? They get one viral infection, then another, then another. So then that's why they have one whole week of fever. Not many viral infections will, with one infection, cause 1 week of fever. So generally around the 5-day mark. This is not in your, I don't know if this is in your book, by the way, but I'm just saying from my experience, around the 5-day mark, with every day with a fever, especially if it was a high fever, then we're gonna want to test for Kawasaki. Kawasaki also with the fever, it doesn't really respond to Tylenol. So even at 5 days of fever, if it responded every time to Tylenol and it totally goes away, then we're not super, it feels low in the first place and then it responds to Tylenol, the fever goes away. The suspicion is very, very low. But anyway, all that to say, Kawasaki disease, high fever, those two things are linked. Looking at the list here, right? So, okay, there's blood vessels all over your body becoming inflamed. Where might you notice that on an assessment? You will notice it wherever blood vessels are densely packed close to the epidermis, right? Close to the surface where you're assessing, where your eyes can see. So where on your body do you have blood vessels really close to the surface? Your hands and feet. So you get the swollen hands and feet. Your tongue, you get the strawberry tongue. Where else? Your lips, fingers, toes, right? So in a lot of these ways, So those are going to be really the characteristic signs. So sure, rheumatic fever had joint pain, but so did Kawasaki disease, right? So you're going to see that a lot of these kind of symptoms kind of blend in between all the different diseases, and it's hard to keep track of all those. But if you're just trying to identify it, a lot of times it's going to be obvious as long as you remember the pathophysiology behind it. So I talked about the high fever. But like I said, a lot of this stuff is really non-specific. The irritability, the fact that they may be afebrile and subacute stage. Okay. Also, Kawasaki disease is a little unusual in that it'll go from these three different stages: acute stage, subacute stage, to convalescent stage. So we have to be. They're not out of the woods just because the symptoms go away. They have to usually have like several follow-up visits with a cardiologist at least, and usually needing a treatment for quite a while. So that is also an important concept to understand about Kawasaki disease. It's a little different from the other ones. So they have these three phases. In the previous slide, we talked about rheumatic fever needing long-term antibiotic prophylaxis, but it's not like rheumatic fever itself has several stages of the disease, right? And the same thing with infective endocarditis. It does need sometimes a long time of antibiotics, 8 whole weeks possibly. But there's not like different stages of infective endocarditis it's moving through. But Kawasaki disease, there is. So what are we going to give? When you think about some kind of systemic, so I said it's systemic vasculitis, right? Blood vessels all over your body becoming inflamed. What are you worried about? Coronary artery aneurysms. That's when you think about a blood vessel that you're really worried about if it's becoming inflamed, you would hopefully think about your coronary arteries. And what do we give for that? Aspirin. So now we have those three things that we give aspirin to children for: atrial septal defect post-operatively, rheumatic fever, and now Kawasaki's disease. So Kawasaki disease, you can see the list here, blah, blah, blah. Okay. Another important thing that we give is intravenous immune globulin. This is one of those things where we're not exactly sure why it happens. I tried to dig around a little bit to see if there's any new research on why this happens, and they're thinking that it has, there's some research to indicate that it may have like a negative feedback loop effect on your T helper cells or something along that effect. But basically, we don't know why it helps. But we do know that it helps slow down we know what it does, what effect it has, in that it helps bring down the inflammation. But in terms of the mechanism of action, exactly in terms of how it does that, we do not know. So a quick word about arrhythmias. Supraventricular tachycardia, you should be fairly familiar with this already. This is something that happens in adults and children. But like I said, like with digoxin, because children's heart rates differ, any kind of tachycardia, any kind of bradycardia, the parameters are a little bit different. So supraventricular tachycardia, the parameters are listed here. 220 beats per minute in infants, 180 for children. But we're going to treat it the exact same way. Vagal maneuvers, possibly cardioversion, possibly even ablation if needed. And of course, medications as well, right? Possible adenosine. So those are all for supraventricular tachycardia. Bradycardia, don't really see that much. Anytime you see bradycardia, like I said in the respiratory chapter, is an ominous sign. It's a sign of respiratory failure. It's a sign of failure in general, especially in young infants. You may see it in older children, sure, but in the pediatric world, bradycardia is not something we see very much. And if we do see it, then it's very bad. Long QT syndrome is an arrhythmia that you should know for pediatrics. When it comes to arrhythmias, most of them are things that you acquire over time, right? Over a long history of a lot of times bad things you do to your heart, right? Like eating terrible foods and smoking, and et cetera, et cetera. Long QT syndrome is unique in that it's an inherited rhythm disturbance. If you remember from pharmacology, you may remember them saying, hey, this old medication prolongs your QT interval. So you might have thought, like, why does that even matter? That's because, like, for this, for QT, right? You got this like Q, QRS, T. The longer that this goes, this T interval, the longer it goes away from your QRS syndrome, as it's repolarizing. If the heart depolarizes while it's repolarizing, then you can cause ventricular tachycardia. And so, basically, you can think of it like the ventricle should just totally squeeze, then totally relax, totally squeeze and totally relax. And this QT syndrome has to be nice and short in order to make that process nice and easy. If it's really long, if it takes a really long time to have a repolarizing of the ventricles, then it allows a really large open window for a depolarization to sneak in, right? And so while you're repolarizing, part of your ventricle depolarizes, then you run into this weird cycle where it just short circuits. The electricity, instead of moving down the nice pathway from the SA node, right? If you have your heart right here, it's supposed to move on your SA node down through here and through your Purkinje, like down the ventricular septum through Purkinje fibers. And instead of doing this nice one direction pathway, it just short circuits here and it goes around in circles and circles in the ventricles. So all that to say, long QT syndromes are bad, and long QT intervals are bad. Long QT syndrome is an inherited rhythm disturbance, and sometimes the way that this presents may be, hey, there's a child, they're playing in a park, suddenly a baseball hits them in the chest, they drop down and die. No past medical history. What might have happened is they had undiagnosed long QT syndrome. During this prolonged QT interval, while their ventricle was repolarizing, that physical trauma from the baseball caused this really minor depolarization. And that depolarization triggered ventricular tachycardia, and maybe that caused them to die. So all that to say, long QT syndrome is inherited rhythm disturbance. We can easily detect it on EKG, but it can go undiagnosed as well. Your ATI book goes into cardiac caths pretty well. So look over that in terms of post-op things to do. Shock is very similar with adults and children, so I'm not going to go into it too much. When it comes to early and compensated shock, hopefully you're fairly familiar with most of these signs.